Okay, guys, I just wanted to finish this up. I'm going to try to hit a few points on some of these last few slides for you. Just remember the terms urolithiasis versus you may see the term nephrolithiasis. Really, they're essentially the same thing. It's just when you see urolithiasis, it means it could be anywhere in the whole urinary tract system, and nephro really refers to a stone really being in the kidney. But lithiasis as a term means stone formation. It's the most common type of obstruction of the urinary tract, and you can kind of see how prevalent it is. Obviously, in the southeast, we have the highest incidence of it, and it's primarily due to the factor that we have, high heat in this area, which causes more dehydration in people. And if you have crystals that are already in your bloodstream and passing through your kidneys, in terms of a salt substance or an element, the more dehydrated, the more those elements come together and form crystals because you're more dehydrated. Males tend to get this much more than females, Caucasians more than African Americans, and as you can imagine, it occurs more often in the summer. Here's just some examples of some. Here's some of the ones that we looked at too today. You can kind of see here's some that are sitting up in the kidney itself, whereas then they eventually begin to kind of move down the ureter, sometimes due to pressure. Some may stay in the kidney, kind of obstructing flow. These are some of the types of stones. Make sure that you're familiar with all of those from a patho standpoint. How does each type develop? What kinds of foods are associated with those developing? You want to know what oxalate high foods are, because you're going to teach a patient that has an oxalate stone to be careful to decrease their intake of oxalate high foods. Patients that have gout may be highly have a propensity for having uric acid stones as well as oxalate stones. So kind of knowing how that works is important as well. And struvite, you do see those from time to time. Those are usually associated with urinary tract infections. And cysteine are sort of uncommon because they're from a genetic recessive defect. Often these will be kind of asymptomatic until they really get obstructive. So you won't know you have one until it starts to pass. The symptoms are pretty extreme, as you've seen on those videos from some of those patients. Very dull, severe aching flank pain that travels down to the lower pelvis. Men may feel this as it travels, like a radiating pain through their testicles, whereas women may feel a pain through their labia. Nausea and vomiting are very common, as well as symptoms of UTI and fever. Patients may look like they're cool and moist and kind of diaphoretic because of how severe the pain is, and you nearly always on a UA are going to see blood in the urine as a result of the stone's movement and kind of tearing up the tissue. You can develop what's called hydronephrosis because of the buildup of urine back behind where the stone is. And again, it has these same kind of symptoms along with infection type symptoms. You can develop infections from having a kidney stone, including pyelonephritis, urosepsis. And if something stays blocked up for too long, technically the kidney can be irreversibly damaged and it can't really be fixed. Usually if the stones are not symptomatic, they're treated very conservatively. These are some of the diagnosis type parameters that they use to try to determine what type and if indeed they do have a stone. This is just a picture of IVP that we already talked about today, and a cysto. Treatment for urolithiasis includes usually very high-end narcotic analgesics because of the severity of the pain, and dilaudid IV is a good choice. NSAIDs are used sometimes for inflammation, cutting down on that. Thiazide diuretics might be given, a drug like hydrochlorothiazide or some of the other ones we've learned about that are diuretics, because it pulls out kidney calcium out of the bloodstream as part of its diuretic function, and so that helps to cut down on the circulating calcium. Alpha blockers, such as a drug like tamsulosin or Flomax, is a muscle relaxer that specifically works on the urinary tract. So all the muscles that kind of line that urinary tract kind of instead of contracting around a stone, kind of ease up, and that allows the stone to maybe pass easier. For patients that have high uric acid levels, they may give allopurinol as a med, and this is a med that's also given for gout, but it helps to kind of cut down on oxalate and uric acid stones. Fluids, obviously we're going to flush these people out. Some references say 3 liters a day at least, some say 4 liters a day. They do need to change their diet to address the type of stone. So in terms of prevention in the future, things they need to lay off in their diet. And we as nurses are going to always strain all their urine to see if there's any evidence of the stone that has passed from the kidneys, the ureters, the bladder, down into through and out through the urethra. Surgery may be recommended, or procedures related to stones that are larger than 5 millimeter, or if there's an infection that requires intervention. Lithotripsy, we've already talked a little bit about, and at the end of class I was mentioning how patients that are for this procedure, you need to always assess their use of blood thinners or antiplatelet, any kind of med that may affect making them more easy to bleed. You want to, that is a contraindication, so they may have to be off their meds for a period of time until this can be attempted in their blood levels for INR, PT-PTT, maybe down back to a lower level. There are surgical removal techniques as well to get the stone out if need be. This is just a picture of the lithotripsy. This is kind of what it does. We saw this earlier today. Just making sure that you know pre-op and post-op kind of how you would manage this patient that's having a lithotripsy. They're going to be NPO before, they're going to have a bowel prep. That just helps with visualization when they're in there trying to do this. You're going to get very frequent vital signs, usually your typical post-op vitals. You're going to monitor the amount and color and clarity of their urine, because it's not uncommon after this to notice some blood in the urine that you can visibly see. Sometimes they may have a urinary catheter, or they may have a catheter that actually comes out of their ureter to the outside. You want to really inspect the areas of the back where this shock wave was initiated fairly frequently, looking for any signs of bruising, hematoma. They may need ice packs applied to that to slow bleeding if you should witness that. And then you want to do really good discharge teaching so that they don't have recurrence of this. Prevention is the key thing, because once they've had a kidney stone and the situation that causes it, their risk for having another one is 50% higher. So pushing fluids on an ongoing basis and adhering to dietary changes as needed is highly recommended. They want to try to avoid dehydration, and I'm sorry for the typo there, but they do need to have 3,000 mLs or 3 liters per day, trying to produce at least 2 liters of urine a day. That's important for those that are active in sports, because they tend to be out in the heat and exertion, having problems more from dehydration, which leads to the development of these. Same thing can be said for tea, cola, and coffee. All those are ones that precipitate dehydration, so you're better off to make sure that they're not using those except on a limited basis. Low sodium diet is recommended, again, to kind of stay away from dehydration. A high calcium diet is okay, but the use of calcium supplements is sometimes avoided because of the development of calcium, more so from those than from dietary calcium. You want to limit foods with high purine and oxalate, and those are there so you can really become familiar with those. Polycystic kidney disease is an inherited genetic disorder where you have fluid-filled cysts that develop in the nephrons. So this is a problem that's high up in the kidney. It has a lot of the symptoms of some of the other things that we've talked about. One key difference is you tend to have increased abdominal girth with this problem because of all the swelling in the cyst and fluid retention around that area. And the compression of these fluid-filled cysts presses on the venous system as well as the arterial side for the circulation through the kidney, and can cause death of the tissue if it's too much pressure. Clearly you are going to see these patients have hypertension that comes from the renal artery being compressed a lot. So severe hypertension is a key sign for polycystic disease. They may have all the other kinds of things, and they can be a high risk for aneurysms because of all that pressure on the kidney. Again, treatment for PKD, you're going to treat all the symptoms. If the pain cannot be under control, sometimes they may have to have a nephrectomy to control the severe pain. And then they eventually, their kidneys, because of all this pressure and cyst development, end up typically with them being an end-stage renal disease that may lead to dialysis of some sort, and their kidneys not functioning anymore. These are some key things we talked about in terms of urinary retention, problems that you can see, that we already said earlier, like that can cause backup of fluid for different reasons in the urinary system, not being able to void properly. This is what you often see, is you'll see just enough peeing to kind of overload the little bit of the bladder, but never fully emptying it. You may see a real distended bladder, and so suprapubic areas kind of swollen, distended. You may percuss over that, and it's a very dull sound. And then, of course, we use the bladder scanner to kind of see how much fluid, using ultrasound, is actually still in there. And there's a picture of that. Treatment, a lot of times you want to really try to remove obstructions. If they're present, so if you're having strictures and that's what's causing you to be able to, retain urine, then fix that surgically. Sometimes you have to have an indwelling catheter or intermittent straight cath to kind of relieve the pressure. If you have, sometimes the males that have the prostate enlargement, they may have to have a Coudet catheter. You can see a picture of that, how it's kind of stiff and curved on the end, and that kind of helps get around the stiffness of the prostate if it's pressing in. A lot of patients may need to be taught to self-catheterize so that they're not having this urine backed up in their bladder. And then there are some cholinergic meds, one of those being urocholine, that can be given to kind of tone the bladder a little bit so that they're a little more likely to be able to empty better. Incontinence, you'll get a whole lot more, although we've talked a little bit about it. Adult Health 2 gets into more detail with it, but there's just a little extra information. And how to treat incontinence is on these meds and procedures on the charts there if you want to look at those in your book.